Thank you very much. So this is about maternal mortality in Sudan. It's not going to cover everything, but it's just going to take, I'm going to take kind of an overview and a specific view on this topic because it's massive. Yeah, so I'm going to give you kind of a broad overview of the country, in addition to some statistics about maternal mortality in the country. But I think the most important part of this is putting maternal mortality in context, so it's within country context, not within the global context. So looking at that in context and then thinking about how can we think about what we're doing differently given that context. So this is more a food for thought. I'm not going to give you any concrete conclusions about that. It's probably a lot of questions coming out of this, but it's a good stimulating exercise, hopefully. So Sudan is an African country. It sits astride North Africa and Sub-Saharan Africa. Sometimes it's classified as part of North Africa. Sometimes it's just an African country. So right now, it's composed of 18 states. It used to be divided into 15 states. The most recent division is 18 states. Khartoum State harbors the capital, and this is the most populous state as well as the most urban. All the other states are mostly rural states, up to 80% rural, for example. I mean, you probably already know that it has a complex political and economic context. It's classified right now as a lower middle income country. That's up from being a low income country. But the economy is struggling. So the cost of, the income is high, but the cost, relative to the World Bank classifications, but the cost of living is really high right now, and the economy is really, really struggling. And since its independence from the British Empire, it has gone through many, many years of authoritarian military regimes, so experience with democracy is very, very limited. A lot of conflict that has been going on for a really long time, ever since independence. New conflict everywhere, and a lot of internal displacement. On top of that, as you can imagine, there is a general disregard for human rights, including women's rights. So against this backdrop, we're not surprised that Sudan is one of the countries with a high maternal mortality rate. How high? That has been quite elusive. It has been very, very difficult to measure maternal mortality. What you read in UN reports, those crisp, nice figures, are not counts. They're not, they are generated through very, very messy processes from very messy data. So in the past, maternal mortality was measured with indirect methods, like the sisterhood method, which kind of averages maternal mortality over the past 12 years. So what you get is something that averages the past 12 years. You don't know what that means or how to, where to locate that in your plans or in your trends. But a lot of people have been working and playing around with that. So this is what it looks like, a clean version from the Global Burden of Disease estimates, showing that in 1990, it was between 300 and 400 maternal deaths per 100,000 live births, and has been declining ever since. So as I said, it has been, it's a lot of messy work has happened behind that, but hopefully the best quality work that had happened so far, given the huge analytic effort that went through it. But what that doesn't give us is what's happening within the country. We still don't know, what are the trends within the country, what's happening within the country. Or actually, we didn't know until 2010. In 2009, maternal deaths became, it was mandatory to report maternal deaths. That's when the maternal death review system was established. So that's a huge jump from using indirect sisterhood methods to actually counting maternal deaths, reviewing them confidentially, establishing the causes. You know what the maternal death review, how it works. It's a huge step. There's still a lot of space for improvement, but that's a far cry, and that's where we start to, we can still look from indirect methods within countries, but that's where you can actually stimulate local planning. As I said, and so this is from 2010 to 2018 using actual counts, and it still shows a decline. It's lower than what you would expect. Starting with 209 per 100,000. These are the official figures. It combines facility and community deaths. And so you can imagine with 70% of deaths occurring, of births occurring at home, how much reporting is happening from the community and how much underestimation there is. But we take this as kind of official figures. Hopefully the trends, the patterns reflect something. Within country patterns, based on this, might still not be reliable because the system itself is developed to different levels within each state of those 18 states. So you can't trust the levels of reporting and to give you accurate patterns or differentials. But overall, what the Ministry of Health has been reporting is that the gap between states has declined, has been the lowest since they started measuring in 2018. And I know I'm just going to give you a bit more information because I know people are now curious about what, if you have a maternal death review, what is it showing? So, so we have, this is just a flyover summary of what the statistics say in the various reports that I had access to. And the top 3 direct obstetric causes have been the same all the time. They are hemorrhage, eclampsia, and sepsis. Accounting for more than half the deaths. Indirect causes, indirect obstetric causes account for about 10 to 20%, depending on which report you're looking at. About 3/4 of deaths occurred in hospital, but we know that most of the births occur at home. Not only that, is that the first delay, so there are 3 delays. And this is terminology that's very commonly used in developing countries because of those kinds of delays. They're not quite as common in developed countries. So the first delay is when there is a home birth and there are complications, but nobody seeks care. Second delay is when they try to seek care, but they just can't get to a hospital. And the third delay is when they get to a health facility, but they don't get care as fast as they need to. So the first delay was the major contributing factor in most of the deaths. So if that's happening, you can imagine there are a lot of deaths that had occurred in the community that haven't been reported. So this slide is going to be kind of a prelude to the contextualization. And I'm sorry it's not clear, but that's how it was in the report. I couldn't make it any clearer. But if you could just look at, oops, sorry. There is a hump here, and there is a small hump here. These are the states, and they're not organized in any specific order, and that's why you see these 2 humps, because, random 2 humps here, because those are the states that experience a lot of features of marginalization. And so in different ways, so low literacy, high poverty, low availability of health services, different kinds of or different features of marginalization. And so I'm going to go into these, I picked a few examples of these features and just to show, and I'm going to show you how they correlate with maternal mortality at state level. And how they kind of, they cluster with maternal mortality. And the aim of this is not to reach any causal evidence on anything. This is just putting maternal mortality in context. Evidence has been established linking those at individual levels. But this is a look at the country by state where decision makers are made, where state ministers of health are, are responsible for the implementations, the administrative level where decisions and plans are made and implemented. And so this is a little, it's not exactly contextual, but it just shows you how utilization of antenatal care, seeking or by skilled personnel, is associated with maternal mortality at the state level. So these data They don't come from the maternal death review. As I said, the maternal death review is, because it's a relatively new system, it's really hard to trust the patterns by state because they are in different levels of development. So the reporting from them may not reflect the actual trends. This comes from the latest survey, the Sudan Household Health Survey 2010 final report, which used indirect methods, but at least antenatal care by skilled birth attendants, by skilled personnel, or all the other variables I'm looking at are going to come from the same standardized methodology and survey that measured maternal mortality. So that's the best way these are the best data to use for this purpose. And so higher states with higher proportions attending antenatal care have lower maternal mortality. Same with skilled birth attendants, even stronger correlation, where higher proportions within states accessing skilled birth attendants or states with higher proportions accessing skilled birth attendants have lower maternal mortality. This is in the context of availability of healthcare. So this is primary healthcare availability. Again, we see that states with higher availability, higher primary healthcare units per population have lower maternal mortality, higher hospital availability, lower maternal mortality. And this is about some measures of norms that are related to gender. Child marriage before the age of 15. Again, higher states with high proportions of child marriage, higher maternal mortality. And then I picked female genital mutilation because there has been for a very long time, a lot of anecdotal evidence that female genital mutilation is associated with maternal mortality and morbidity, but only until maybe 5 years ago that really serious efforts in getting really high quality evidence were made. And there was a Lancet paper that showed that it was associated with higher risk of maternal hemorrhage, although there is something in the methodology that it wasn't an assessment by a person who knew that the woman was cut. So it's hard to really trust that evidence, but that remains the best available evidence. There are other studies, at least one study in Sudan that associated it with, I think, maternal mortality, but the evidence is very scarce. And when we look here, it's actually the opposite. So states with higher proportions of FGM have lower maternal mortality. And I think we shouldn't read much into that. I think this has to do with ethnicity as well. Those states with high maternal mortality also tend to have ethnic groups that do not practice FGM. So this is just quite circumstantial. I think this is quite circumstantial, but at least it kind of it's the FGM, and it has a very high prevalence. And if you're talking about anything maternal, you need to kind of look into that. Socioeconomic, going higher up, socioeconomic level, higher proportions of poverty in the state associated with higher maternal mortality. Again, I'm not talking about very strong correlations, but at least we're doing this exploratory look, and that's how it reads. Adult women literacy, again, percentage of women who are literate. So higher proportions, states with high proportions of women who are illiterate have lower maternal mortality. So this, there are probably a lot of other indicators. We haven't looked at transportation. We haven't looked at educational systems. We haven't looked at the entire context. And these are really important parts. This is what's available, and it's really hard to be comprehensive here. But it says something about, I think, how we've been approaching maternal mortality for a long time, within country or in global health, which is, the two are definitely connected, because what's happening within countries is driven more by what international donors think need to happen and what they're willing to fund, because the countries don't have the money to fund themselves. And so how do the current priorities look like? So it seems that the way things are being done right now favor the language of acceleration. So we want to accelerate, and we want to do this very fast, and we want to bring down maternal mortality so you can achieve that global target. And so its focus is on kind of low-hanging fruit, working with what's existing, the easiest things, in-service training the staff that you have, improving quality, assessing and improving quality. But what happens if, there is one of the huge problems, especially in rural areas in Sudan, is staff turnover. You can't keep people. So, why can't you keep people? Because they don't have a lot of, they're not paid well, they don't have opportunities for their kids, the educational system may not be well developed, they want better opportunities. So it's so highly linked, and I don't think that the way things are done now are, take that into account. There is, and this is just one example of how these, everything is so strongly linked, and that we're not looking at those, hard at those links. And so this kind of hinders long-term investments, and that's a challenge. How can you convince people to put their money in and wait 100 years until you see a return for that, especially if it's not your money? So I think there are a lot of opportunities here. The Minister of Health has started to kind of, it's a political issue as well, maternal mortality, because the imprecise measurement had caused a lot of embarrassment for the government, so it has become a political issue, and there is huge drive to reduce maternal mortality and appear good. So they were able to get a lot of money, their own, and they were able to kind of look at much, long-term system building investments. The issue of silos is quietly, it's related. You have silos within the health system, but also the health system is siloed from the other systems that also matter. And the challenge here is how to break through these silos. The opportunities, a lot of opportunities have presented. We've seen a transformation in planning of maternal health care. It has been linked with child health care, very strongly linked. So now they are in one strategy. They used to have different strategies. Adolescent health is coming in, so there is a lot of integration that's happening. And hopefully that could help break the silos even out from across the health system to other non-health sectors. The issue is definitely cannot be separated from human rights. The simplest is the right to education, literacy, all the way to, making decisions, staying in school, not getting married early. So that full spectrum, it cannot be separated from human rights. It's a difficult conversation in the country because of the way the political system is set up. It does not encourage these conversations. The religious sentiment that is continuously drawn into these kinds of conversations that kind of put women aside and do not give them a voice. And so the opportunity here is, the new framing of maternal health as a human rights issue and bringing in human rights into the global action plans. And hopefully these conversations will pick up. But we definitely, if you want to address education, if you want to address all the factors that affect maternal health, poverty, you need to talk about human rights if you want to bring them under one umbrella. Data and research, as we have seen, prior to 2010, everything was indirect. You couldn't do a lot with maternal mortality. The estimates that are gathered are not quite usable, but to estimate maternal mortality, so no deeper research. Maternal mortality itself is a relatively rare condition, so you need huge amounts of money to actually carry out meaningful studies. So most of the studies would have been either hospital-based or looking at common related conditions like conditions during, anemia during pregnancy and things like that are, easy to actually to do with a small amount of money. So that kind of set back research. Hopefully the maternal death review is going to enrich data in that area. A lot of surveys, a lot of opportunities, I think, to use existing data to inform policy and practice. And yeah, I'd like to acknowledge at this stage, I've received, Dr. Nada Jaffer, who has been the MCH director in the Federal Ministry of Health from 2013 to 2019, has been helpful in supplying me with the reports that I've been missing, as well as having conversations to kind of brainstorm. Otherwise, all views in this presentation are mine. Thank you very much.